Good morning, everyone, and warm welcome to today's first seminar on working with underserved communities in public health research. My name is Opeyemi Babtunde, and I'm delighted to be chairing today's session. We are pleased to see such a broad mix of colleagues from local government, the academia, policy, and practice joining us on today's seminar. And today's session focuses on evaluation and how evaluations can be designed to support local government work in practice. So, and also we want to look at how we can, engage underserved communities in meaningful ways and what it looks like, sorry, pardon me, in real FIRST projects. Before we go on, I just want to tell you a little bit about FIRST. So before we hear from our speakers, I'll briefly set the scene for those of you who may be new to FIRST. FIRST is funded by the National Institute for Health and Care Research and was established to respond to a very, very practical challenge, which is about supporting local authorities across the UK who are actually delivering innovative public health interventions, but they often do not have the capacity or resource to evaluate them very robustly. So FIRST bridges that gap by pairing councils with academic teams to co-design and deliver timely policy-relevant evaluations. So what does FIRST do? A key strength of FIRST is its flexibility, and all evaluations are cost covered, and councils don't need a fully formed research question when they do apply. And the scheme supports a very, very broad view of public health projects and ranging from mental health and gambling to free school meals and active travel. FIRST has grown substantially since 2020, and learning from project is not only intended to support local decision making, but also to build a shared evidence base that others can build on or draw on in the future. So if you would like to keep up with FIRST activities, outputs, and future opportunities, you can follow us through the channels that are listed on the screen, including FIRST website and our mailing list. These channels also showcase a wide range of outputs beyond traditional reports, which is very, very relevant to today's theme. A quick note that throughout the 2026, NIHR is marking its 20th anniversary. We're celebrating the impact of research funded by the public and for the public. This milestone is a good reminder of the importance of equitable, inclusive research and of working closely with communities and partners to generate evidence that genuinely makes a difference. Just a little bit of housekeeping before we go on into our seminar today. To minimize the disruption, I would really want to encourage everyone to keep their microphone and cameras turned off if possible. Please post any questions or comments through the chat box. We'll be drawing on this later and picking them up. And live captions are being enabled via more actions and then language and speech for people who need it. And the slides related to these FIRST blogs and also other FIRST evaluations that we've done on the website. Just also to make us aware that today there are elections taking place in many places across the UK, and our focus today will be on involving underserved groups in research. We kindly ask that presenters and commenters are asked to refrain from any political statements. Now, I just want to introduce our speakers before we go on. Today we have Dr. Sarah Janac and Sarah Robert and Dr. Anna Boath from PHIRST Elevate teams. They're from the University of Edinburgh, and they're going to be talking to us about Best Start for Baby program in Camden. And then we will then have presentation from our PHIRST Elevate colleagues, PHIRST Elevate colleagues, still the same presentation, and they're going to be also joined by Dr. Freddie Thompson, who is a clinical psychologist. Secondly, we're going to hear from Dr. Tricia Jessiman from First Insight from the University of Bristol, and Bev Pattison, who is a public partner on the FAME study. Bev has actually volunteered with Age UK in Lincolnshire for over 6 years, and we will hear about implementation and engagement challenges from First Insight and the work that they've done at the University of Bristol. And finally, we'll hear from Dr. Krysia Canvin from PHIRST PHRESH at the Keele University. Krysia is Research Fellow in Involvement and Engagement at the School of Medicine, and she's also Academic and Research and Innovation Inclusion Theme Lead in the Midlands Partnership University NHS Foundation Trust. She will be sharing with us, we'll be drawing learning from the Phoenix and Athena project. And the presentations today will be followed by a panel discussion where we would explore shared themes around trust, engagement, and what good evaluation looks like when we're working with underserved communities. I'm now going to hand over to our first speakers. And please, as a reminder, please add your questions to the chat box at any time, and we will come back to them during the panel discussion and the Q&A later on. Thank you so much. And over to you, Sarah.
Yep. Hi, everyone. Can you see my slides?
Yes.
Yes, good, fantastic. Thanks, everyone, for joining. So I'm Sarah. I'm part of the PHIRST Elevate team based in Edinburgh, and I'm presenting on an evaluation we're currently doing in Camden with my colleague Anna. And later for the panel, we'll also be joined by Sarah Roberts and Freddie Thompson, who are both working on the health visiting program in Camden. So thank you very much for joining. Before I kind of dive into the evaluation we're doing and how we're trying to engage with underserved communities, I'd like to invite you all to do a little thought experiment. So to kind of put yourself in someone else's shoes. Someone can't see the slides. Can I just confirm everyone can see the slides?
I can see them, Sarah.
Everyone can see them. Okay, good. Good. So imagine you have recently arrived in the UK after leaving a conflict in your country. You're living in temporary accommodation in Camden and have a new baby. You are adjusting to a new system with some support, but without your usual networks close by, and you're continuing to develop your English. Despite this, you've been finding ways to care for your baby and respond to their needs. You're beginning to notice their cues and what helps them to settle, and there are moments you enjoy together. You've been attending the family hub where you have had some positive experiences and support for you and your baby. So that's sort of the background. And now imagine that a member of staff asks if you would be willing to take part in a focus group linked to health visiting. What might go through your mind at that moment? What might help or make it harder for you to say yes? So please take a minute or two, put yourself in that person's shoes, and I'd be really interested to see what you think. Please use the chat. What might help or make it harder for you to say yes to join this focus group? Yeah. Loads of suggestions in the chat there. Good. So I've tried to summarize some of these, but I think there are more in the chat, but these are the key ones that we try to think of. Things like, one big one that people keep mentioning in the chat is what is a focus group? Maybe even what is health visiting? Thinking about language barriers, my English is not good enough. Logistics, where will this be? How do I get there? Why me? So, you know, what can I offer? Am I good enough in a way for this? Maybe people being nervous about big groups, or nervous about, you know, what happens if you say no? Can you still access the family hub? Can I bring my baby? And, you know, can I receive a voucher if they've been offered a voucher, if I've recently come to the UK? What exactly? And I'm just looking through the chat. There's loads of suggestions there. Yeah, will someone look after my baby? Being a bit suspicious. Fantastic. Thank you, everyone. That was really helpful. And I hope that helped set the scene a bit about how we were trying to kind of overcome some of these barriers. I'll move to the evaluation, a bit more context on that. So we're doing a health visiting evaluation. The program in Camden is called Best Start for Baby, and it's enhanced health visiting service. So there are extra appointments there compared to what is offered in other councils across the UK. And what we're really focusing on in this evaluation is equity and reach. So we are working, or we especially want to focus on 5 groups, 5 different communities. I've listed them in the box there. So we want to look at the experiences of Black African and Black Caribbean families, Bangladeshi families, those who have experienced perinatal mental health difficulties, dads, and families who live in temporary accommodation. And that includes families experiencing homelessness, refugees, and asylum-seeking families. So if you want more information on that evaluation, I've put a link there, and we should be completing this summer, so the full report will be available. And in this presentation, we will focus especially on the last 2 groups, mainly on families who live in temporary accommodation. That's what the sort of thought experiment was based on. And we'll also touch upon dads, because that was a very different strategy to engage with them. I'd also like to point out, we're based in Edinburgh. This is an evaluation in Camden. So it's pretty, you know, big distance to cover, even by train. So we really couldn't have done this without local support. So a big thank you to our embedded team members, Rosie, Freddie, and Susie, who have been really instrumental in recruitment and engagement and really getting this evaluation going. So thank you very much. Good, I'll hand over to Anna, my colleague, who will discuss a bit more about how we try to overcome some of those potential challenges that we identified together. Thank you.
Brilliant. Thank you so much, Sarah. Good morning, everyone. My name is Anna. I'm one of the research fellows at PHIRST Elevate, and it's lovely to be here and talking about our evaluation in Camden this morning. So as Sarah said, we're going to focus on 2 out of the 5 groups, but obviously if anyone has any questions about the specific groups they'd like to pick up after the seminar, please feel free to email us. We'd be happy to help. So in terms of families who live in temporary accommodation, we really were conscious of utilising trusted relationships and face-to-face engagement, and that's where having kind of boots on the ground, especially the work that Rosie and Freddie did in the community to work with their partners. So for example, the family hubs that are familiar to a lot of these people, the homelessness outreach teams, Family Lives, etc., to work with them to then do the recruitment that way, as well as an open call to participants. Something that was really important during the recruitment process was that participants themselves were able to select a group that they relate to. So perhaps they were experiencing homelessness, however, they might have actually felt that they would rather be in a group talking about perinatal mental health, as that's something they had also experienced during either pregnancy or postpartum. So we made sure that they were absolutely in control of a group that they joined if they did decide to join a group. And just taking it back to the thought experiment that Sarah did with you there. So these were some of the ones that you've all brilliantly come up with, but the ones we thought about before we started our recruitment strategy. So we took a long time to kind of go through all of these and make sure that we did some preempting so that our recruitment strategy could be as sensitive and effective as possible for this group. So we always encourage people, if they've got babies or small children, to be able to bring their baby along, and support by having creche workers there so that they know that their baby is in a safe and supportive environment. And also doing these at familiar locations, for example, the family hubs where they've perhaps been before. We also offered taxis for this group, and any group, in fact, particularly in the case where people might not have money for a train or a bus fare to get to the family hubs, and to allow that flexibility. And again, with scheduling, we offered groups through the day, but we also offered evening groups if that was more suitable for people and their schedule. As well as offering a voucher as a thank you, we wanted to provide a meal just in the case of the homelessness the group. We just wanted to make sure, our temporary accommodation group, because we thought that would be kind of appropriate, and we worked with the team in Camden to deliver that. And we also acknowledge that not only in the group in temporary accommodation, but in the other groups, people might want to do a one-to-one interview, particularly as they might have experienced trauma or what they were discussing was particularly sensitive. Again, we offered translators in person if possible, so that people could participate in the groups and there wasn't that barrier of language there, so that we could get as many views involved in the groups as possible. And that kind of came through in the consent forms and going through with the consent forms with them. And we were also really grateful to Freddie for coming along, particularly to the perinatal mental health groups, as a trained clinical psychologist who could provide signposting, information, leaflets, and was also on hand to offer any debriefs, not only for the participants, but also any staff in the building or ourselves as researchers, so that everyone was very supported. One thing that we did come up with in terms of our reflective practice about what we might do differently next time was what a video of what a focus group might look like. So we would answer any questions, but we thought after discussions, I think it was Susie who brought it up, was that a video of what a focus group might look like could be more effective for individuals, particularly if English wasn't their first language, or anyone with neurodiversity. So that was something we came up with in terms of reflecting on our journey through this evaluation. And not to steal Sarah's thunder as the knowledge broker, but we very much go, and I'm sure a lot of you do, around nothing about us without us, and how do we circle back. So in terms of the 5 groups that we've worked with throughout this evaluation, we want to make sure that we feed back what we've learned from the evaluation to them, and it doesn't feel like they've been part of the evaluation and the information gathering, but they're not part of that knowledge mobilisation and feedback loop. So Sarah is currently working with a lot of the parent champions in Camden, so that we can work out the best way to feed back to those communities so that they understand their valuable contributions to the work that we've done. And just briefly to touch on the dads that we recruited for the evaluation. So we spoke to 6 dads, and we found that that kind of cold calling approach wasn't very effective. So we ended up recruiting them via WhatsApp groups, so recruited 4. And a very important thing there was that we found that scheduling focus groups after kind of the traditional workday was much more important. They didn't tend to have as much flexibility in their schedule. In this particular area, we found that a lot of people were working that typical 9 to 5, so being able to participate was very much dependent on being able to come after work. So thank you so much for listening to us. We're happy to take any questions, and if you'd like to send us an email, our mailbox there is open for any questions after the seminar. So thank you so much.
Thank you very much. So we'll now move on to the next team now. Tricia?
Thank you. I'll just share my slides. Can everyone see that?
Yes,
Go on the main slide.
Yeah, there we are.
Yeah.
Thank you. So just to introduce ourselves, I'm Tricia Jessiman. I'm PHIRST Insight based in Bristol, and my colleague has already been introduced, but it's Pattison, who's our public partner for the study. And we're going to be talking about the evaluation of a falls prevention service for the over 65s.
Okay, so what we wanted you to have a look at, if you've got time after the webinar, is to have a look at this video, which gets you to imagine yourself at risk of falling. The video is a reporter trying to navigate with an age simulation suit on. You can see it looks almost robotic in this slide. He's walking downstairs, trying to negotiate the stairs with stiff knees, swollen ankles, large feet, trying to hold the banister whilst holding a walking stick in stiff hands. And his eyesight is impaired. I think he's wearing goggles in this. And he's trying to see, his perception is altered of the stairs. This age simulation suit is one that the instructors who run the programme that we're going to be talking about are encouraged to wear when they're training, so that they can empathise with the frailties of old age. I imagine that most of you listening to this are under 65, but it's true in England that those of us over 65, there's about a third of people who fall a year, and that increases to 50% if you're over 80. So there's obviously a need within the community to reduce the risk of falling, and this programme is aimed at that. My experience as an older person, and my colleague Barbara, who we were both public members, came to help with the research programme and wanted to focus initially on what it feels like to be older. The falls cause pain, obviously, initially, distress to those around us. If you're out in public and somebody falls, you possibly had that experience. It's very stigmatizing for the person, and often, I don't know if you've fallen recently, but if you fall, you look around first to see if anybody saw you, and that feels stigmatizing. Obviously, there's risk of serious injury, and the stigma around falling. Your family look at you as if you're at risk. People lose confidence, don't walk downstairs, don't always use the lifts. So one of the things the programme is trying to do is get people to think about what the risks of falling are and try and reduce those. And Tricia's going to talk initially through the programme.
Thanks, Bev. So the Falls Management Exercise Programme is a 6-month group exercise programme for the over 65s. There's no upper age limit, so some of the people attending are quite elderly. I think the oldest one that we had was in his late 90s. It was delivered across Lincolnshire, which itself is quite a large county. It's very rural with a few coastal towns, and we conducted an evaluation back in 2023-24. It was a mixed methods process and impact evaluation. So we collected some routine data from over 100 participants who'd taken part in the programme. And that was just data about their mobility. So measures of things like how long it took them to walk a short distance, or how many steps it would take them to turn a full 360, trying to get some measure of their mobility and how that changed after the programme. But the main aspect of this presentation is the work that we did, which was qualitative work. So we conducted interviews with those commissioning the service, those who managed it, and the instructors who were delivering the classes. But we also wanted to interview participants themselves, so those who had taken part. And also we had some of those who dropped out of the service for a number of reasons, and even those who were offered and were eligible to attend but decided not to. So we interviewed 35 older adults, and in some cases also their partners or carers that they lived with. And finally, we undertook observations of the FAME classes themselves. So one of the things I wanted to emphasise in this presentation is how important public involvement is when working with underserved communities, and it's a real key part of how we approach this work. So we will always co-develop our studies with our local authority partners. So those who are commissioning and managing a service, we'll work with them to design the study aims, the questions that they want answered and the methods that we should use. But we also have embedded within public involvement. So in this case, we were very lucky that we were able to recruit 2 public members, Bev, who you've heard from, and also Barbara. So they are older adults. I wouldn't describe them as elderly, but they are older adults who live and know Lincolnshire very well. They're also really experienced in supporting older adults through their voluntary work with Age UK, and we worked with Age UK to contact and recruit them. And they were part of our study management team from the very beginning. So we held, when we were developing the evaluation, we held a face-to-face workshop in Lincolnshire. A few of us travelled up from Bristol to design the study and our methods. But we also had frequent online meetings throughout that development phase that Bev and Barbara were part of. And we met with them separately throughout the study, and we had face-to-face and online meetings, and they really helped to shape and also manage the study throughout. So one of the first things we had to think about, a little bit like the last presentation, was how were we going to recruit older adults to the qualitative aspect of this study? So because of the population type, we sort of already knew that online methods wouldn't work, that our interviews had to be face-to-face. But thinking about the nature of this group, they were by definition had mobility issues. Probably many of them had falls already, or perhaps illness that they were dealing with. So we knew that the best place to do that was in their own home. But that can be quite challenging to recruit. It's quite difficult to invite a stranger into your own home. You might feel quite vulnerable, not quite understand what the research was about. So the first thing that Bev and Barbara told us is that we really needed to meet people first. So I would go along to FAME sessions. Normally after each exercise class, people would stay behind for half an hour and just have a cup of tea and a bit of a social chat. And I would go along to that half hour and just sit with people, introduce myself, what the research was about. They could chat to me, ask questions. And that actually it was so valuable. And we recruited most of the older adults in that way. It would just seem much easier and more accessible for them to agree to take part and invite me to their home after they had met me. Bev and Barbara also helped us develop accessible study information sheets. So you'll know that quite a lot of our information sheets for research are quite technical. They have language that's difficult to understand. So Bev and Barbara helped us amend that and make them accessible as possible. And we also had an audio-visual version. So there was a QR code on the leaflets that we handed out that people could click on with their phone and just watch a video of me reading that information sheet. So if anyone had visual problems, they could use that. And actually that video was accessed quite a lot. So we knew that people were doing that. I've talked about why we wanted to interview people in their own home. And the other thing that Bev and Barbara wanted us to do, they were really good at thinking ahead to the end of the study and how we would be communicating our findings back to people, older adults in Lincolnshire. And they strongly felt that if people were thinking about attending a class, maybe they'd seen something about the research, they would want to know what that class was like. So they wanted us to observe the classes so we could describe things like the venues, where they took place, how accessible were they, what actually is a class like, what are the exercises that you do, what are the instructors like, what kind of interactions happen between the instructors and participants and between the participants themselves. So we were able to describe that and feed that back to potential participants at the end of the study. I'll just hand over back to Bev and she can talk about the qualitative interviews.
Okay, so Barbara and I were involved in looking at topic guides for the interviews. And one of the things that Tricia's already mentioned is that we wanted to make sure that the language, was accessible and acceptable to older people. And an example of that is that when we're asking about falls, quite often people describe older people as having a fall. young people seem to fall or fall over, but older people have a fall. And there's a seriousness about that that's perhaps indicative of the stigma around older people falling. So we wanted to make sure that we didn't talk about having a fall that was stigmatizing, but that people fell, as I said, quite regularly if you're over 65, once a year, or 50% of people over 80. So it's quite a usual thing for people to fall, sadly. So this program is about, obviously, about helping people develop the skills physically to help them reduce the risk of falling. So we were clear that people fall over and they don't have a fall, and I'd like you to take that away. If you take anything away, that would be useful for you to take away from today. We also felt that it was important, thank you for that, it's important that older adults were allowed to talk about the accessibility of venues. Some of the, as Tricia said, the Lincolnshire county is an enormous county, mainly rural. So a lot of the venues were church halls, etc., community centres, which are great and really well thought of in their communities, but their accessibility, their doorways are often not very wide, their car parking can be tight, and also in rural areas, there's not much accessibility in terms of buses. Those of you who live in rural areas would be aware of that. In fact, Lincoln itself, though it's a city, has quite a poor bus service. So getting to venues like our central venue of Park Street in Lincoln is actually quite difficult for people. So thinking about accessibility. One of the other things we thought was important was thinking about the timing of the FAME classes. Getting up in the morning is obviously quite a challenge for many of the older adults, and getting to places for early sessions can be a challenge, and it can be tiring. So that has an impact on the rest of the day for people attending the class. One of the other things we wanted to emphasize was using the FAME exercises at home, that once a week for 24 weeks is quite a long time, but actually you're living this life all day, every day. So thinking about practicing the exercises and building that strength and good postural strength is really important. So those were things we wanted to ensure were in the qualitative interviews. In terms of the questions for commissioners and managers, again, we wanted to ask about class venues. Were they suitable? Were the chairs suitable? I think we've all probably had the experience of sitting on wonky, uncomfortable chairs in small venues. So trying to avoid that, taking control of things where people could. It was also important that commissioners and managers looked at the recruitment of FAME instructors, because it's quite a long training process, an intensive training process, and therefore retaining those instructors is really important. And then thinking about the workload of the managers, so asking questions about that. We also reviewed some of the anonymised transcripts of interviews. And when we did that, we picked up that participants were sometimes lonely, but definitely at risk of being lonely. And that led to Tricia carrying around some information she could share and leave with participants that she interviewed. And I think that improved the signposting to other organisations. Barbara and myself were also involved in the analysis of the research. And to do that, I think Tricia's already mentioned that we had 2 face-to-face meetings in Lincoln, which is our central hub, which again, for people to get to is quite difficult. Barbara was down in Boston, which is quite away from us. Within that, we read the transcripts, we looked at the observation notes, anonymised obviously, and we had a view of the analytic framework. So I think I've already talked quite a bit about the accessibility and the quality of the venues, which was something that was a theme throughout the scripts we read. One of the next things that we felt was very important was the instructor's approach almost the unmeasurables, really. The charisma of some of the instructors. Some of them used music, which seemed to be very motivational. I'm not saying that we asked everybody to do that, because for some people it didn't work or might not work. We also felt that when we read the scripts, that the way the exercises were explained and that Tricia had observed, when they were related to everyday activities, they seemed to be very successful, or more successful maybe. So that if there were wrist exercises, hand exercises, what's the relevance of that, people might ask? Well, you might be opening a jar or pulling a seatbelt across yourself to fasten that in a car. So those sorts of exercise, turning, etc., were explained. Those instructors that had the best interaction with the participants seemed to do very well, and that interaction seemed crucial. Some of them were able to have a coffee before the session, and we looked at some of the transcripts and we felt that the interviews, the social sessions after the programme were the most fruitful. Certainly that was the feedback people gave. We were also interested in programme integrity, whether the programme was followed in full. The exercises are cumulative. They get more difficult the more the programme runs on, which makes sense because people have developed their skills. And some of the participants obviously were wary of some of the exercises. One of the key exercises is getting up from the floor, and that, I think, on a couple of the observations had been allowed to slip for some of the participants. So it was making sure that the programme integrity was followed. We were also aware from the transcripts that some of the participants had extra health challenges. In fact, many of them did. They may have had heart problems, vertigo, other disabilities. So thinking about that and how you're going to deal with those within the programme was important in our view. We looked at the challenges and the advantages of having carers and partners involved during the programme. And the advantages were clear, I think, because they could reinforce the training from the programme and not do things for their partners or the people they care for, encouraging them to do it for themselves, encouraging them to open the jar, etc., whatever it was. And we felt that was very important. The challenge might be finding venues big enough to get everyone in there. And then finally, I think I said earlier about issues around transport and the mobility in rural areas. And we designed an information sheet, which Tricia's just going to go through.
Thank you. Yeah, we'll just finish off by saying that Bev and Barbara were also involved in co-producing a public-facing infographic about the research and the study. And it was aimed at the older adult population in the county, and we left it in places where they would be able to get it. So places like GPs and some pharmacies. And that was just a very brief explanation of, as Bev has talked about, the risk of falls, what the classes were like, what the study found. And actually we found that the FAME intervention was quite successful in falls prevention, and how to get involved and join a class if you wanted to. And finally, the information leaflet just finished it with a couple of quotes about the impact of taking part, the increase in confidence and staying active that it had on people.
And we wanted to say, kind of round off the circle by looking at the difference the programme made to one participant. They could finally get up off the floor on their own, which they hadn't done for years. And we felt that was very important in terms of impact of the programme.
So thank you for listening. There is a link there and probably in the chat if you would like to find out more about the study. The full reports are on our website.
Thanks, Tricia and Bev.
Thank you.
Over to you, Krysia.
Hi, yes, thanks, Yemi. I'll just share my screen. I'm just going to warn you that during this meeting, I've dropped out 3 times. So I don't know why, but of course it's typical. So many apologies if that happens. Right, can people see my slides?
Yes, if you can just put in the, yeah, perfect.
Super. Okay, I just popped out again. I don't know if this is going to work. So I'm going to tell you about Project Phoenix and Athena. I know we're running behind time, so I will try to go through these relatively quickly. One of the things I really wanted to kind of mention before we get into this, because there's a different kind of population that we're talking about. Everyone, you know, many people have babies and get older. Not as many go to prison, but I just wanted to sort of make people aware the health and social inequalities that people leaving prison face. And this is one of the photographs taken by a participant in our evaluation. And the quote that he put with this, saying about how you know, a tree needs certain conditions in order to be able to thrive, and for many people that's not the case in their lives. They don't have that supportive community and those opportunities. And I think it's just quite a nice way of going into this again, because I want people to sort of realise that thinking about people who've been in prison, it's not a niche topic, it's not a niche area. Dropped out.
You're fine. Krysia, we can still hear you, or we can see you. Could you say something, because I can see you?
Right, yes, it was the link had gone, it was making a noise. So okay, so I want to say it's not a niche topic. There's a great number of people in prison, around 90,000 people, only 4% of women, that's important to mention. Most serve very short sentences, less than 12 months. And so this means that there's around 250,000 people passing through the prison system each year. And that means there's around 50 to 60,000 people returning to the community every year. This means that, you know, people in prison do not stay in prison, they are members of the community. And, you know, some of the health inequalities that they face, they have high rates of physical health problems, high rates of learning disability and learning difficulty, so literacy and cognition. Almost half have mental health problems, and between 30 and 40% report problematic drug use. One of the most shocking things to know is that around 25% of people in prison have been in local authority care. And when you focus on, can you still hear me, Yemi? Because
very well, yes.
oh dear. Am I back in?
Yes, you are in.
Sorry, it keeps dropping out and it makes the noise, and I can't see what you can see because I can only see my slides. So so yes, and if you look at then under the under 21s, it's as many as 50% are care leavers, which is extraordinary. Over 60% of people in prison are unemployed and 15% are homeless. So they haven't got those support networks in place, and they've also got a lot of unmet needs. Projects Phoenix and Athena. Just want to sort of again give you a flavour of the impact that they have on people's lives. So we're thinking about that tree and needing those that community to grow up in. And this is how some of the people we spoke to described Phoenix and Athena. saying that they'd probably be dead if they didn't come here, or they'd probably be on the streets or back in prison. So what do Project Phoenix and Athena do? Well, they're funded by North East Lincolnshire Council. They're delivered by Wiser, which is a community interest company, and the managing director T is online, going to join the panel later. And they essentially offer mentoring and support, emotional and practical support with these different areas of people's lives. They also, crucially, work with other agencies. So there's weekly meetings with stakeholders from other agencies, housing, probation, police, and substance recovery services. The kind of support that they provide is very much personalised and individual to that person's preferences and needs. And everyone is allocated a recovery navigator who has lived experience of being in prison. They start off by meeting people whilst they're still in prison. They often meet them at the gate when they're released, and then the support continues. Few other crucial things to know about Project Phoenix and Athena. Hardly any eligibility criteria, although they do tend to work with people who are going in and out of prison a lot, and people at risk of substance use or overdose. People can self-refer, they don't have to be referred by an agency, and there's no big key performance indicators, so there's no demand on Wiser to get so many people into work or to prevent so many people being recalled to prison. There's also no limit on how long they spend with people, how many sessions they have, and people can leave and come back as many times as they wish. So I think it's helpful to think about, when we're doing research with underserved groups, about how we make reasonable adjustments in order to make sure that people can contribute, and that then we can design interventions and services that fit their needs and not just the needs of the majority. And again, bringing it back to what it's like when you leave prison. Again, this is another photograph taken by one of our participants. And as you see, he says he took this because when you get out of jail, you're a nobody. You're just a tiny speck in the bigger world. You're of no importance and you're of no relevance. And so this is the mindset coming out of prison, and it's worth knowing that within that first week of release, there's a very high risk of people dying, either from overdose or other reasons. So what can we do? We have to try to manage some of the challenges. So the health and social inequalities that we've mentioned. People have a lot of trauma in the past. They are very stigmatized, and unsurprisingly, not very trustful of authority or official procedures. And yet research tends to be very prescriptive, very rigid, makes a lot of assumptions about what people want to do and can do. And also we're not very good at detecting modest kinds of impacts. So where there is very small increments of improvement, or where evaluating interventions that are very individualized makes it difficult for us to do evaluations. And this makes problems for not just for people leaving prison, because they then end up being ignored. Quite often they're not believed anyway. People don't try to understand them, and they can feel very disempowered and excluded. And research is an opportunity to demonstrate that doesn't have to be the case, and to give them a different experience of the world and let them have their views. For researchers, we might have concerns. This list obviously isn't exclusive, but might be concerned about whether people are going to be able to understand the information that we provide and the format we provide it in. It can be really difficult to make contact with or make arrangements to meet someone who perhaps doesn't have a fixed place to live, who perhaps doesn't have a phone. And obviously, it's also really difficult establishing trust and rapport, especially if you're perceived to be someone from a very different background or life experience from them. And everyone, wants to be sure that people are fully on board with taking part in research, not being coerced or pressured into doing something, that everyone is safe, researchers and the people taking part, and that we can look after people's confidentiality. I have put these strategies here again. It's not an exhaustive list. I find that just being very, very flexible and responsive to people's needs, asking them, don't make assumptions, giving lots of choices, and I'll give you an example of the choices that we provided in this particular study, and making sure that we are genuinely listening to people, and then communicating the value of what they've told us was so important. We always develop what I call distress protocol, and again that's for both the researchers and for the participants, so that everyone feels comfortable in terms of, if someone becomes upset, how can you recognize that? What should you do next? What support can you get? What support can we direct people towards? And also, especially with this community, being very clear about when you might have to breach confidentiality. So if there's a risk to somebody's life, for example. And then in terms of capturing impact, trying to focus in this project, we're trying to focus on trajectories, and also adjusting our expectations around, so we might not report, as I say, reduced recalls to prison, but we do have other smaller achievements that they're not small to the people who've made those achievements, but to just adjust our expectations in that way, and also by looking at those processes and active ingredients that are making the intervention work. So we gave people a really wide choice of ways that they could contribute their views about Phoenix Athena and their experiences, and there was a varied response to these. The important thing was we were so keen to make sure that people could choose, and not to assume that nobody wants to write things down. In prison, it's quite common for people to keep a notebook and keep a journal and use that to sort of write their thoughts. But in this case, in this particular project, nobody wanted to do that, which is absolutely fine. But it's so important that they have the choice to do it. As you've seen, we use photo voice, which is a way of collecting data and then using that to support an interview. And you've seen some of the photographs that we used from that. And just to bring that round full circle, this is another one of the photographs that one of our participants took, and a reminder to ourselves about capturing impact. And for this person, this was the first certificate that he'd had since he was at primary school, so very, very young. And that's an immense achievement. And, I think acknowledging this and conveying that within our data collection and our findings is really, really important. There's so many people involved in this project, and I'm so grateful to all of them. Everyone is such a brilliant team. Too many people to thank, but I will leave it there. Thank you.
Thank you so much, Krysia, and all the presenters.
I'm so sorry if that was difficult because of the I don't know whether it dropped out for you or if it was just for me. So
you
sorry.
were good. It was perfect. It was all right. Don't worry about that. Thank you. Right. So thank you so much. And we've really had very, very engaging and stimulating conversations going on in the chat box, which you're going to get to in a moment. But now that we've had all the presentations, I would like to invite all the speakers back. If you could put your camera on, and we're going to just go through a set of panel questions right now. Thank you. Right. So just before we go, and even some of the questions that we have, the audience have started, highlighting some of those things. But I just want to ask you first, especially for PHIRST Elevate, in hindsight, what do you think you could have done to facilitate the focus groups? I saw interesting reactions to your earlier poser when you said, what do people think people will be going on to? So what do you think? How do you think we can facilitate the focus groups, or probably even invite them the way we invite them to kind of lessen their anxiety about such kinds of involvement? Yes, Sarah.
Yeah, I can take that one. Yeah, so it's a really good question, and I think we did a lot of reflection after we did sort of the first round of recruitment. One thing that we think worked really well is that sort of relational approach, using existing relationships, working with embedded researchers and the sort of groups that work with the communities we are trying to reach. So we think that worked really well. In hindsight, I think we mentioned in the presentation what would have been really good was to maybe show what a focus group looks like. And this is not just for working with these specific communities. I think that's something that in a lot of focus groups, I think that would be really useful. I think we sometimes, we do, it's our bread and butter as researchers, and we don't think that might be a term that's not that commonly used and people might not know what it means. So showing a video of what a focus group looks like and what is involved. And then another thing, with the patient information sheets, we did participant information sheets. We did have, translators working with the participants. But again, that's something we could have maybe done in advance, a bit similar to what Tricia did. That video, I thought that was a fantastic idea, and doing that possibly in different languages is something I think that would have been very good.
Yeah. Thank you. And I was thinking probably something a little bit also more interactive that probably feels more like an FAQs and feels like their own questions that could come in their own voice, like, what if I don't want to do this? What if I'm afraid of, joining this? Would it affect my benefit if I take a voucher? Those kind of things might seem a little bit even more relatable to those groups. So thank you very much, Sarah. So I'm gonna move on to the Project Fame right now. So what methods did you use to recruit participants to the research if they declined to take part in the Fame intervention? So if they were not part of the Fame intervention, but you wanted to include them in the research, what methods did you use?
Thank you. Yeah, I think it's always important to try and recruit people to research who are eligible and have been offered a service, but for whatever reason decline to attend. And I think that's really important if it's a targeted intervention that's hopefully been designed with underserved communities in mind. And in our case, there were quite a few people who were referred to Fame, but when the delivery provider contacted them to tell them about the exercise classes, they didn't want to come. We couldn't get the contact details of those non-attenders directly. There's just data protection and ethical reasons why we couldn't do that. So our initial approach was to ask the delivery provider, who were great, actually, they were really helpful to us. And they sent a letter to people who had refused the service, telling them about the research and inviting them to contact us directly and take part in the study. We didn't get any response to that, which I think is not surprising. If you're not interested in the service, you're not really going to be interested in any research about it. So we did a couple of things. Because the initial contact for the delivery provider when they were inviting people to the service, that was a telephone call. And so when people said they didn't want to come, the delivery provider started recording the reasons why and shared that with us. And so we had a kind of a record of why people were saying no. And generally, I mean, it's what we talked about really. Often it was about transport, or where people, since they'd been referred, they might have had additional illness or accidents that led to that decrease in mobility. So they just weren't able to attend the class. But it was still, we still wanted to talk to them. We wanted to flesh that out a bit. So we went back to our ethics committee, which was the National NHS HRA committee, and asked them that when the delivery provider made that initial phone call, could they tell non-attendees about the study and ask for their consent to pass contact details to us? And that was just their telephone number. And actually our committee, the ethics committee, agreed to that as long as we only phoned people once. So that meant that we could phone non-attenders directly and just ask a couple of questions about why they didn't want to come. And we did manage to recruit quite a few people that way. And that was really helpful because when we spoke to them, yes, it was about transport mobility, but it was actually, it was also that some people just don't like group classes. They would have preferred a one-to-one approach. And I think we can all understand that. So yes, it's an important group to try and recruit to your study, those people who decline the service itself. And I think it's just about keeping at it and trying a few different recruitment approaches and not being afraid to go back to your ethics committee and asking for amendments if you feel that you need to.
Yeah, that's really, really helpful. And I'm sure some of the insights that you got from them would really help in either for the council to reflect on how else they can provide these services, or what other methods, what other modifications they can do to target those people who are probably not taking it up, and remove those barriers. Thank you so much. I'm going to move to Krysia Canvin, Project Athena and Phoenix. And I'm just really interested in learning how you adapted your evaluation design and data collection methods to reflect the individualized and trauma-informed nature of Phoenix and Athena. How did you adapt your evaluation design and data collection methods?
I'm so sorry, Yemi. It dropped out again as you were speaking. Like, the timing of my teams today is just
yeah, that's
immense.
fine. Don't worry. I'm gonna repeat myself. So I said I'm interested in learning about how you adapted your evaluation design and data collection methods to reflect the trauma-informed nature of the people that were in Project Phoenix and Athena.
Yes, it's a really good question because and I mean, I think to some extent this is not something that I would only do for this particular project. It's something that I think we all need to start thinking about doing for all projects, because lots of people have trauma, and you know, things can crop up in interviews, for example, without people realizing it. But in this project, so I think one of the key things, and I have put a note in the chat, actually, I've not spoken about the sort of lived experience involvement, but I think one of the key things that you can do is engage people who are already within that community and who are already viewed as safe, to help kind of broker between yourself as a researcher, a new person going into that community and asking personal questions and, you know, trying to make contact, having them vouch for you, but also, you know, seeking advice from them about what kinds of things you need to be aware of before you start delving into people's, you know, personal business. And also to be aware then of the kind of support that either they, for example, in this case, Wiser, you know, what kind of support do they have in place already to deal with those sorts of things that happen. But I think, again, you know, I mean, I've got to say that the team that went to Lincolnshire and collected the data were absolutely amazing, and we had a lot of discussions around, you know, recognizing distress, being sensitive, being aware of how people, you know, the things that they might be carrying and how to deal with that and how to respond to that in the project. And I mentioned the distress protocol. And we got so much support as well from Wiser in terms of facilitating all of that and creating that safe environment. And, you know, and I don't know if I've already said this, but I think giving people choice So, you know, making it very clear that participation is absolutely voluntary, and also that it can be. So we did do interviews with people, but they could also just have a brief chat. If they don't want to sit down in a room that might feel a bit like an interrogation, you know, they could have a chat in the corridor. You know, it was as flexible as that. And again, I think that really helps with ensuring that people don't feel re-traumatized, you know, in terms of that kind of, you know, being interrogated, asked lots of questions, searching questions, you don't really know what they're going to ask about. So yeah, don't know if that helps, answers your question.
Yeah, thanks, Krysia. And that leads me to my other question, which is quite open to any of the teams presenting, really. I wanted to check what has been the hardest trade-offs between rigor and responsiveness, because I think Krysia started touching upon that. So I'm sure you've also done a few adjustments along the way. So how did you manage the trade-offs between that rigor in research and evaluation versus responsiveness to the population that you're trying to evaluate? Thank you. It's really open. Anyone? Yes, Krysia, go on.
I would contest the idea of, I think first the initial answer is about transparency. I think as researchers, as long as we are transparent and systematic about the things that we do and how we then describe them, I think we've got a distorted idea about what's rigorous and what isn't. I think when we're doing research and huge swathes of underserved groups are not being involved because of the way that we do research, that suggests to me that actually that's not very rigorous, you know. So to me, it's not so much a trade-off. I think it's something that as researchers we have a responsibility to start doing. And if we have concerns whether the way that we're doing things, for example, in these studies, which I have no doubts that we you know, they are completely fine. But if we were to have, then we need to start developing new ways of doing things and new methods, new measures, you know, more sensitive measures, involve people with lived experience in designing those measures and designing those studies to capture the, you know, the impact that actually matters to them, and do things in a way that they actually want to contribute to.
I mean, I would also add to that. I completely agree with that, Krysia, and I think we just have to be careful about what we mean by rigor. I mean, research rigor to me is I think we confuse it sometimes with rigidity, and that's not what we mean. You know, it's still it's to me, it's about good science. It's about transparency, reliability, our credibility, how we can transfer this to other populations. And I think as long as we stick to those principles, I don't think that is the challenge. I mean, we've talked a lot in all the presentations about things we can do, about adapting our methods, about co-creation. In some of our studies, we've used peer researchers and training for those, but we still have principles that we stick to so that we have good science. I actually think the challenge for us in kind of real world, and especially first evaluations, has been able to do all this in quite time and resource constricted studies, you know, and as you've seen, we're often working at quite a distance, which makes more life you know, doing all that stuff a lot more challenging as well. So I don't think we've got a problem with rigor, to be fair. I don't think using flexible methods presents a challenge to that at all.
Yeah. So that's really, really reassuring. Thanks, Tricia. And I'm now going to move into individual questions from the audience because we've got loads of them. We'll see how much we can answer before our time runs out today, but they're really good questions. The first one I really want to take up. It says, do the public members have input into the evaluation metrics? And how do you measure what is important to them, as well as what is important to the commissioners? That's a really great question. Anyone? But I knew that came out from when the FAME was being presented, but I'm sure this applies to all the studies as well. So over to you.
Initially, my response to that is yes, we did, but Tricia might be able to explain how that filtered through. But we were involved in right from the beginning of the FAME programme evaluation. We talked initially very early on at the first face-to-face meeting, which was, I think there were about 19 people at the first one, and it was a bit daunting for the public members, I think, to get involved with it. But I think that set the scene, and I'll hand over to Tricia to tell you what the scene was, I suppose.
Yeah, thanks, babe. Yeah, they were involved. If you consider a topic guide a metric of what we were measuring and what we were interested in, then yeah, I mean, Bev talked about all the changes that they made to that and all the questions they wanted us to ask that we otherwise might not have thought of. We were slightly challenged with our routine data because we're using standardized clinical measures of mobility. So people were less able to influence that. We couldn't influence that as our researchers because we would have invalidated the measure, but we did add metrics. So there was a question in the chat about loneliness, and loneliness came up quite early. And again, that was something that was raised by our public partners, that we needed to be, that one of the potential impacts of the programme was on loneliness, and also to an extent social isolation, although I recognise those are different, but it was public partners that influenced that, and we introduced a loneliness measure to our study as well.
That's really helpful. Thanks, Tricia. And I'm going to move on swiftly to the next question about someone asked, when we're co-developing research or services, have we had difficulties with managing expectations? And if expectations are unrealistic, how do we navigate this? And I think, again, this cuts across all the projects. If there are unrealistic expectations, either from the commissioners or probably even from the communities that we're working with, how do we manage them? I think this is a really, really challenging question.
I'm going to jump in.
Go on.
Do you want to go ahead? Oh no, so I was going to say I'm going to jump in because I'm very aware we've got Freddie and Sarah on the call, who have done an immense amount of work in Camden around involving the parent voice through their development. So I'm going to put you on the spot, Freddie and Sarah, because I know you've done a lot of work. If you'd be happy to maybe talk a little bit about the development of Best Start for Baby.
Hi everyone, really nice to be on the call, and thanks to the presenters today. So yeah, I think we had rapid expansion with the Family Hubs funding really from central government in 2020. So there was a kind of rush to action, and I really think the kind of stepping back, pausing and reflecting, so certainly interrogating the data, there are lots of kind of resonances with other aspects of work that have been discussed today. Yeah, stepping back, pausing, working with the workforce around reflective practice, anti-oppressive themes, cultural competence, really reflecting and kind of interrogating what we're doing and who we're kind of reaching in a meaningful way. And I think working through really established trust relationships with other professionals in the system, but also outreach strategies, community providers, VCS, that was kind of really, really important, but definitely kind of driving multi-systems change. And I think one of the challenges in designing universal services is we design universally, but I think the people who are racially minoritized and marginalized really need that there's complexity, there's richness, and we really need to think about how we adapt. And I think reaching out to those individuals has felt really important throughout the work, particularly around perinatal mental health and parent-infant relationship work. It brings up so much for people, and I think that's felt really emotive and really important. Like, is that kind of enough and sufficient? Yeah, lots of workforce development as well around kind of systemic approaches, reflective practice, really thinking about supporting the workforce with that complex thinking.
Okay, I think Bev would like to weigh in. Sure, go for it.
Sorry, I cut across you earlier. I apologise for that. One of the things about managing expectations for the FAME project was very much, it was certainly an expectation of mine that people had good access to the FAME programme, because you research it, you say it works, and I'm sure that that's true for all these projects. How are the public going to access it? How are you going to, you talked about universality. And that was a real frustration for me as a public member, that there wasn't an open access to the FAME programme, and it's nothing to do with the research team. We proved it worked, and how are we going to use it? And that seems really important to improve the life of people, older people in Lincolnshire. So I don't know, we didn't really hit that one at the end of it. I'm still questioning how we access it. Just a little anecdote, there is a programme, a FAME programme being run at our centre in Lincoln. So I know weekly there is one programme, but the need is much bigger than that across the county.
Yeah.
Tricia, have you got any comments on that?
No, I think you've nailed it, Bev. Thank you.
Yeah, and I'm gonna stay on that part a little bit, but I really want to take this follow-on question is a bit back to also expectations, really, but in a different way, relating to metrics and how we measure. So there's been a recent question in the chat box from Diana about where funders and journals and probably even commissioners would expect validated standardized tools as outcome measures, but those measures don't resonate with participants and what they understand and what the impacts they really want the intervention to have. So really, how do we reconcile these different expectations, but more specifically towards metrics, measuring what's meaningful to participants versus measuring what is meaningful to funders and the commissioners, what they need to show to prove that this is working or not. Any thoughts, guys?
Well, sorry, I'll start, but I mean, I think this is an age-old battle between, qualitative and quantitative research, isn't it? But I think increasingly funders and commissioners do want qualitative approaches where you can ask people, you can do the public involvement work to make sure you're asking the right and relevant questions and people want to be asked, but you also can, within that data collection, encourage people to speak openly and raise things that they would want. And I think that evidence and that is increasingly valued, and sometimes I would see more valued. People they want that kind of rich data. So yeah, that's my approach. But then I'm a qualitative researcher, so I probably would say that. But I don't know if anyone else has anything to add.
Yes, go for it, Krysia.
Try to turn my mic on. Yeah, I completely agree, and I think that we shouldn't underestimate the power of stories. And again, I'm bound to say that because I'm a qualitative researcher, but I do think that can be the element that gets something onto the agenda, that gets some the attention of people, and in these kinds of interventions that I think we do have to make more of those, really.
Yeah, I think I'd agree with all the comments. I think there has been a shift in kind of a shift towards lived experience and narrative approaches in kind of shaping commissioning. And I think we've noticed one of the most powerful things is having experts by experience, sitting actually in the sort of decision making around those meeting structures at kind of a very senior level and influencing systems in that way. So that for us has been particularly influential, and taking videos. I think, yeah, that kind of content is really influential.
Absolutely. And maybe this also follows on to, again, engaging with established systems, what the norms that we know. There was a question in the chat box about ethics, about ethics panels and how flexible they were to amendments, which is a common issue for qualitative projects. And I guess the question I wanted to ask is, when we need to make adjustments to evaluation metrics or even any other parts of the project, how do we engage with ethics, and how does that affect the timelines and the deliverables on the evaluation, especially because we want to make it sensitive and responsive to the people that we're trying to serve in these evaluations? What do you think?
I mean, I personally, when I submit an ethics application, I try to make it as open and flexible as I can, and make it very clear that I want to be able to respond to what people need. And I don't think I've had to go back with amendments for that reason. But you know, it depends on the project entirely whether you're able to do that, and obviously what people ask for and your budget.
Yeah, okay. And I think what you said is really, really important there, especially when we're working with underserved populations. So we need to be thinking about more innovative protocols and innovative ethics application that actually allows us to respond to the needs on the field as they arise. So that's a really, really important take-home point there.
And I think just to add to that, you know, I mean, ethics committees get a bad press, but actually, I think something that they are really interested in is involving more underserved groups in research. And if you say, this is why I'm doing this, you know, that builds the case then for sort of getting their approval and their buy-in to those processes.
Yeah. And probably maybe, I mean, this is not a talk for, it's a talk for another day, but probably maybe underserved populations also need to get onto these ethics boards, because so that they can be more able to interpret the context of work that may be done on the field. I think that's really, really important, because there's some things that you cannot just put in black and white on paper. You know, it needs to be read and interpreted, you know, in the right context. Tricia, you want to say something?
Just a shout out from our experience with the NHS ethics committees, that the fact that we've done so much public involvement in the development of the application. So the study itself, but also the ethics application, that really worked in our favour. That they really appreciated that. And so we didn't get a lot of pushback on the methods that we were proposing.
Yeah, absolutely. Great. We're running really close to the top of the hour. And I just wanted to thank all the speakers and contributors for today. There's a lot of project-specific questions in the chat box. And what we will do is we want to encourage you to look out for the project reports. Some of them are fully completed and on the website, and some of the questions are actually answered. I've seen a lot of questions regarding language framing, and especially with respect to Project FAME, which I think members of the team have started to kind of respond to. And what has come true today is very, very strongly is that working with underserved communities isn't an add-on to evaluation. It fundamentally shapes how questions are asked, the methods that are chosen, and how learning is shared. And PHIRST thus produces a wide range of knowledge mobilization products and outputs, including blogs and creative outputs and practice-focused summaries. And I just want to really encourage you to explore and share these through the PHIRST channels. Han will be putting in the chat box, and it's also linked to the website adverts and all the blogs and poems that has been produced. So I really want to encourage you to engage with some of these ones. On this note, I really want to thank you for all the engagements today and for a very, very, very thoughtful discussion in the chat box. We're really, really grateful. So I'm just going to draw the curtains on the seminar today. Thank you so much, everyone.